So I'm going to talk to you today about neuro-ophthalmology. This is again a very important topic and quite complex in its own way. So I'm going to try and make it simple. I'm going to cover only a few common conditions relevant to your practice, also relevant to the examination, as some of these topics will be definitely asked of you in both the theory and you could get this in the practice. I'm going to talk to you about acute paralysis. Acute paralysis is involvement of loss of muscle. It generally results in acute loss of function of the muscles in various parts of your body. It can be localized, it can be generalized, it can be partial, it can be complete, it can be temporary or permanent. It has various patterns depending on the involvement of the limbs. It can present as a monoplegia, a paraplegia, a hemiplegia, or a quadriplegia. Now, usually if it's a bolt from the blue and it's a sudden onset weakness, it's usually either traumatic or it could be a vascular event, such as a stroke or sudden trauma to the spinal cord. But other differentials can be considered depending on the site of involvement. Now, in the spinal cord, you can have a transverse myelitis, which is a non-compressive myelopathy, and we'll talk about it in a minute. We can have trauma to the spinal cord. We can have an abscess which might suddenly increase in size. We can have a hematoma or a bleed into the cord, or a spinal cord infarction due to a vascular event. Other differentials to consider depends on the localization. So if it's an anterior horn cell involvement, poliomyelitis, which is not seen commonly, can present with acute weakness. Motor neuron disease rarely presents acutely. It's generally a subacute onset, but sometimes a patient can present with fairly acute weakness if the earlier symptoms have not been picked up. As it regards the nerve and the radicals, GB syndrome, which is AIDP, presents fairly acutely, and the weakness can develop in hours to days, or even up to a week or so. Toxins, heavy metal poisoning, diphtheria, porphyrias all affect the nerve and roots with a fairly acute weakness. In neuromuscular junction disorders, botulism can present with acute weakness secondary to food poisoning, but myasthenia gravis can also present with acute weakness, especially of the bulbar or the eye muscles. Coming down to the muscle, myositis is generally subacute, but periodic paralysis can be fairly acute, particularly if it's associated with any dyselectrolytemia. Now, we'll talk about three conditions in detail, as these are important to your examination. The first one being the GB syndrome, which is a rapid onset muscle weakness. It's a flaccid quadriparesis, but sometimes it can be limited to just the lower limbs, it's a fairly variable clinical picture, but the classical GB syndrome will cause weakness of all four limbs. It's caused by an immune insult to the peripheral nervous system. The symptoms develop over an hour to a few weeks. And during the acute phase, it can be fairly life-threatening. Up to a quarter of people can develop weakness of the respiratory muscles as well as the bulbar muscles, and may need intensive care. The first symptoms are fairly widespread in various patients. They can present with tingling, numbness, paresthesias, muscle aches, cramps, and pain. And this is usually over a day or so. Subsequent to that, they develop a rapidly ascending weakness of the lower limbs, which then affects the arms and is fairly symmetric in onset. The weakness is very rapid, but in some patients may have a more stuttering progression over a few weeks. The muscle of the neck can be affected. Some develop facial weakness, bulbar involvement, at least to some extent. Up to a quarter of patients will have very severe involvement needing intensive care. A variant of this is called the Miller facial syndrome, in which the ocular muscles, especially subserving eye movements, are involved, and they may present with diplopia, ataxia of gait, and of course spastic. flaccid quadriparesis. My apologies. The GB syndrome, sensory and sphincter involvement is unusual. Patients with GB syndrome have generally a prodrome of an which, as I've already mentioned, lasts a few hours, and they may have an antecedent history of some infection, usually involving the respiratory tract, or diarrhea, and they may be able to recall this fairly distinctly. History of travel seems to be also linked to the diarrhea. A small percentage can develop this after the post-flu vaccine, and there's been some association with GB syndrome with COVID-19 as well. Examination causes flaccid weakness, and generally the weakness is fairly significant by the time you get to see the patient with areflexia. The tone is fairly flaccid, and patients can have variable involvement of the bulbar muscles. In the Miller Fisher variant, they will develop weakness of the eye movements, and they will be in coordination as well. There could be significant autonomic dysfunction in the form of tachycardia and hyper or hypotension, which needs fairly intensive management. Now, GB syndrome, the pathology varies. In the demyelinating variant, there is damage to the myelin sheath by T lymphocytes and macrophages, and prior to this, there's activation of the complement. On the other hand, the axonal variant of GB syndrome, there is mediated through the IgG antibodies and the complement against the cell membrane covering the axon, and there's damage to the axon, which then causes these patients to have a poorer prognosis as compared to the demyelinating variant, and sometimes they can be left significantly disabled. So once we suspect this, what do we do? The diagnosis is, of course, based on clinical suspicion. We do a lumbar puncture and look for albuminous-cytological dissociation, which means that the proteins are quite significantly raised without any white cells in the CSF. In fact, if there is any white cell in the CSF, one would like to need to consider alternative diagnosis. Nerve conduction studies and EMGs are a gold standard for the diagnosis of GB syndrome, and have classic patterns depending on the form of neuropathy that we see. Either it will be demyelinating or axonal. Nerve conduction, the studies may take a while to do, so CSF is generally the test available at the bedside. MRIs were carried out as a research tool and showed some nerve root enhancement, but these are not done routinely. Various subtypes of GB syndrome have been described. AIDP is the classical pattern that we see, which is the acute inflammatory demyelinating polyneuropathy. You can also get axonal variants, which could be an acute motor axonal neuropathy or acute sensory-motor axonal neuropathy. And then you have the Miller Fisher variant, in which there's involvement of the eye muscles, as well as there is ataxia. The pharyngeal brachial cervical variant involves mainly the upper limbs, the shoulders, and the neck muscles, and difficulty in swallowing, and is a rarer variant of the GB syndrome. So how do we treat patients with GB syndrome? We offer them intravenous immunoglobulin. Generally, it's given over a 5-day course, and may need to be repeated if the disease continues to progress after a few weeks. Plasmapheresis is the alternative available, but it's not easily available, and therefore, because of ease of administration, we use intravenous immunoglobulin. Patient needs a lot of supportive care and may need ventilation in almost a quarter of patients, but we do closely monitor the respiratory function, the bulbar function. We may need to offer a feeding tube until the patient is able to swallow safely. Physiotherapy and occupational therapy have their role as well. There is no role of steroids. It's been mentioned as patients being offered steroids for treatment of the GB syndrome, but is not given routinely to patients. Myasthenia gravis is a neuromuscular junction disorder condition. It's a long-standing condition. It's also immune-mediated condition which causes various degrees of skeletal muscle weakness. The most common affected muscle groups, and which is how myasthenia normally presents with ptosis and diplopia, is the eye muscles and the eyelid muscles, and also the bulbar muscles, which involve the face and the swallowing. In fact, quite a few of these patients are picked up as they're referred to the ophthalmology department and then from there. The pathology affects the neuromuscular junction, and at the nerve ending terminal, the vesicles containing acetylcholine receptor, the acetylcholine is reduced. The acetylcholine receptors on the muscle are also reduced in number and are blockaded by antibodies, and so very few receptors are available, and the synaptic clefts as well at the muscle end are flattened, and so therefore ineffective depolarization occurs, and which causes the muscles to become weaker, especially on repetitive contraction. The thymus gland has been implicated as in generation of the acetylcholine receptor antibodies, and if the thymus is enlarged, it happens in quite a few number of patients with this condition, then they are offered a thymectomy, which improves the management of such patients. If the diagnosis is suspected, we do an acetylcholine receptor antibody test, which has almost a 95% sensitivity. In ocular myasthenia, the sensitivity is somewhat lesser. If the acetylcholine receptor antibody is negative, then we do test for the antibodies to the MuSK protein, anti-MuSK antibodies, which is muscle-specific kinase. A word about the Lambert-Eaton syndrome. This presents almost similarly to myasthenia, but the pickup is usually made on electrodiagnostic evaluation, as instead of a decremental response on nerve testing, you would get an incremental response. It presents with weakness of limbs and areflexia, and there is a strong association with the small cell carcinoma of the lung. 3,4-diaminoparidine has been used to treat this. It's a very rare condition, but the basis of treatment is basically to treat the underlying malignancy, and which will be more effective than offering any specific treatment for it. Now, coming back to myasthenia gravis, we do electrodiagnostic testing, mainly repetitive nerve stimulation, which will show a decremental response. We test about certain groups of muscles, mostly the eye muscles and the facial muscles are the most easily tested, where we give a stimulus, and each response, the muscle action potential, will show a decremental response, which helps us to diagnose this condition. Single fiber EMGs is a very complicated procedure in which we sample single fibers, and we look for certain abnormal potential patterns called jitter or blocking, which help us to diagnose myasthenia gravis, and this is done by a skilled electrophysiologist. We also do a CT of the thymus gland, and if the thymus gland is enlarged, then we consider surgery. There's a very good response after thymectomy, and the need for medication with various drugs does decrease after a thymectomy is carried out. Now, how do we treat myasthenia gravis? One is to, of course, confirm the diagnosis. We also do educate the patient about the condition. We do explain to them what it's all about, and in this we do tell them about avoiding drugs that can worsen myasthenia, particularly there are muscle relaxants, and there are medications, antibiotics such as fluoroquinolone. There's a long list of drugs that's available in literature, and also there are websites which are helpful in educating patients. The website used in the UK is the 𝑭𝒂𝒓𝒛 website, which gives excellent information to patients about dealing and coping with this condition. Acetylcholine receptor esterase inhibitors are the drugs that we use, which is pyridostigmine. It's a 60 milligram tablet, or neostigmine, which is a 15 milligram tablet, which is used mostly in a more acute setting. we don't generally offer patients neostigmine in an outpatient setting. We give them pyridostigmine. We do. It can cause cholinergic side effects, and such as increased tearing, a runny nose, or abdominal cramps and diarrhea, and we need to educate patients about this and caution them that this side effect may manifest. But the specific treatment is immune suppression, and so we do start patients initially on steroids with some stomach and bone protection. Generally, we offer them tablet of prednisolone, but we start on a very small dose, as there's a paradoxical worsening of myasthenia occasionally on steroids, and then build it up slowly. Finally, of course, the drug of choice is immune suppression, and we use either 𝑨𝒃𝒛 or mycophenolate. In some patients, we might need to give them biologicals such as rituximab, and of course, if they have a enlarged thymus gland, we consider thymectomy for them. Now, a myasthenic crisis is a complication of myasthenia gravis, which is characterized by worsening muscle weakness resulting in respiratory muscle failure, and it may present acutely, where patient may present with quite significant weakness, severe ptosis, difficulty in swallowing, difficulty in breathing, and may need to be rushed to the ICU and intubated. Recognition is extremely important if there's any intercurrent infection that needs treated, and we have to be aware that steroids can sometimes tip patients into a myasthenic crisis. Once we've recognized this, we give supportive care. We try to withdraw all medication, because sometimes an excess of acetylcholinesterase inhibitors can cause a cholinergic crisis and can tip people into a very similar syndrome. IVIG is the general treatment of choice, which is administered over 5 days for ease of convenience. So if centers have plasmapheresis, this can be considered as an alternative therapy for patients. We then restart medicines in sequence, and whilst in hospital, get them back on to immune suppression as well, and closely follow them up, and also educate them about recognizing the signs and symptoms of a crisis as well. I'll talk a bit about transverse myelitis. Transverse means inflammation extending horizontally across the section of the spinal cord. It causes a sudden symmetric weakness of compressive myelopathy. Sudden symmetric weakness compared to compressive myelopathy, my apologies, which is asymmetric. So generally, if there's a tumor or if there is a disc, it'll cause a weakness starting from one side and then progressing to the other side, and even then it may not always be symmetrical. A transverse myelitis generally is very symmetric, and the weakness is comes across as a bolt from the blue, and can develop over hours. It's quite not unusual for a patient to wake up in the morning and suddenly find that they cannot weight bear and collapse by the side of their bed. But other patients may have a more progressive course, and this can progress over a few weeks. The weakness is initially flaccid when there is a period of spinal shock, but becomes spastic thereafter. There is a sensory level and a sphincter involvement because the spinal cord is involved. There can be partial myelitis as well if the entire section of the cord is not involved, and the pattern and the weakness depends upon the level. The progressive loss of myelin sheath is the pathology affecting the spinal cord. In fact, transverse myelitis is one of the indicator conditions for multiple sclerosis. Infections can cause transverse myelitis either directly or through an immune-mediated attack as well. There's a vast list of conditions causing transverse myelitis, and I would suggest you go through these and read them at your leisure. Which and a lot of these are treatable, so we treat the underlying cause, but otherwise we first have to confirm the diagnosis, which is made much easier now because we have MRIs available, and so we're able to discern inflammation of the spinal cord. A lumbar puncture is carried out. The lumbar puncture is helpful to distinguish this from GB syndrome, both of which can present with flaccid weakness initially, and The presence of cells generally will swing it towards transverse myelitis. Proteins are raised in both conditions. If there are cells present, it's very unlikely that we are dealing with GB syndrome. We send complete blood workup, including a connective tissue and a vasculitis workup. We test for B12, folate, paraneoplastic screen, celiac screen, and HIV. If we don't find an underlying cause and patient has presented, it could be a first sign of MS, and we do give them a pulse of steroids. We generally use methylprednisolone, and subsequently we can keep them on oral steroids for a longer period of time with stomach and bone protection. Sometimes they help to reduce the inflammation of the spinal cord. They may not be the specific treatment, but helpful in alleviating the patient's symptoms. Supportive care with OT, physio. OT is occupational therapy. Physiotherapy is useful. Care of the bladder, skin is carried out, and if they have 𝑭𝒂𝒓𝒛, then their swallowing and respiratory function needs looking at as well. NMO is neuromyelitis optica. It's a recognized immune-mediated condition, and NMO antibodies are tested for, especially if there's a long segment myelitis in patients, along with optic neuritis. If they're MOG antibody positive with a long segment myelitis, they generally have a better outcome. Both these are treated initially with steroids and immune suppression, and the NMO antibody positive myelitis tends to have a slightly worse outcome. Thank you.